Hello friends, I am Dr. Ravikant presenting bladder dissection that is performed in various different conditions. Why we should learn bladder dissection systematically, as it can happen in cases like this with a previous surgery, fibrosis, and a dense adhesion of the bladder to the anterior vagina or to the cervix can end up in an accidental cystotomy like this, which can be very well easily repaired, but it may increases the chances of morbidity, hospital stay, and even sometimes there can be very rarely leading to the vesico-vaginal fistula. Let us try to understand little more systematically to do the clear separation of the utrovesical fold of peritoneum. Hold the peritoneum very close to the bladder and dissect midway between the cervix and the bladder. Going close to the cervix will lead to we need to dissect more about the fibrous tissue where we may chances of entering into the wrong plane. Going close to the bladder can injure the vesical plexus and again entering into the wrong plane. So midway between these two, and a loose cellular tissue which is very well easily seen should be divided, and then we can see the vesicle with the plexus running parallel to it and a vaginal plexus running parallel to the vagina. So this is the best way of doing the dissection in routine cases. So there are cases where dense adhesion of the utrovesical fold of peritoneum to the cervix, as it happens in the previous cesarean section, which is very common condition nowadays, as there is a rising incidence of cesarean section. Here we can plan lateral window technique, for which the dissection should be done superficial to the uterine artery and medial to it, where we'll get a usually avascular plane can be very well identified. As we do dissection just superficial to the uterine artery, we can get a virgin plane. Most of the time we can find a plane between the bladder and the cervix. Do the same dissection on either side so that you will go well below the bladder, and we can identify the plane of dense fibrous adhesions and separate the bladder from the cervix. Now we can identify the dense fibrotic band, and we can very well see clearly the fibrous tissue which can be identified and divided. So that is a lateral window technique which is helpful particularly in patients where previous cesarean section scar is there and dense adhesions are present, which can be very easily separate the bladder from the cervix and prevent the chances of accidental injury to the bladder. Now we can see very well the fibrous tissue which should be identified and then divided. Bladder can be very well held, and once you cut this scar tissue, further dissection down becomes very easy, where it is a loose cellular tissue is present and it can be very easily separated from the anterior vagina. It is only the at the site of the scar it is densely adhered, and other sites it can be very easily identified. Now we can see one more patient. Here, scar pregnancy. Scar pregnancy, as we are all aware, it happens at the site of the isthmocele or scar dehiscence. It means a scar is poorly healed. So in this case, most of the time, like previous cesarean section, we will have a dense, puckered and fibrotic scar, and utrovesical fold of peritoneum is seen very densely adhered. Sometimes even the bladder fibers have gone puckered deep inside the defect of the scar. So to evacuate all the contents of the scar pregnancy, we need to separate the utrovesical fold of peritoneum and separate the bladder from the cervix well below the site of the scar pregnancy. As in these cases, we need to evacuate all the contents and excise the edges so that fibrotic tissue, which is not healthy and is not good for the healing, need to be excised, and then we should suture the ends. In this case, anterior technique is useful. We can identify the utrovesical fold of peritoneum, hold the bladder fibers and do dissection, fiber by fiber dissection. So once this dense fibrous tissue is divided under vision, and the further dissection of the bladder below the cervix can be performed. So just like we do it in a routine cases, the dissection of the bladder need to be well down as compared to a routine cases of for hysterectomy. Here we need to excise the scar, freshen the edges, and then only we can suture the scar. So you can see this in this patient, a dense fibrotic adhesion is present. So now this is a case where congenitally absent cervix. In this case, the utrovesical fold of peritoneum is very close to the cervix, and the vagina is represented by a band of tissue. That means there is no actual vagina. There is an absence of vagina, and there is a agenesis of the cervix. To open the vagina in this case, so we need to do deep down dissection near to the trigone of the bladder so that accidentally there is no injury. So these are the various different cases where blood is